we're going to talk about how to get a magnified view with photography. Here's an example of a cat with a history of mucoid discharge and squinting in both eyes. It has a normal Schirmer. By the way, I don't perform Schirmer tear tests in cats because I don't determine them to be predictable or that valuable anymore. But we're just going to assume that the tears are normal here. Fluorescein negative and its tonometry within normal ranges. So what do? This is such a classic scenario. We've just got random conjunctivitis. If I were in the clinic, I would take conjunctival cytology looking for the two most common bacterial causes, Chlamydophila or Mycoplasma. With the magnification that we have right now, I don't have any other surface characteristics that tell me what disease this cat might have. But we'll talk about techniques, and with photography, I can get a video that is 4 times magnified, a video where I can get still shots, and you're seeing them on the right-hand side, and I can find superficial vessels traversing through the cornea. I don't see any intraocular disease, and I know that feline herpes virus is the most common cause of keratoconjunctivitis or ocular surface disease in the cat. I don't see any entropion or any eyelid issues that would be causing irritation of the ocular surface. And I now have enough information to diagnose probable feline herpes virus 1 infection, just because I was able to find keratitis. None of our other common causes, we've got those classic 4. Herpes virus, number 2 is Chlamydophila, number 3 Mycoplasma, number 4 Colici virus, but it kind of depends on shelter to shelter and location to location. Herpes virus is the only one that routinely causes keratitis. We diagnose keratitis with neovascularization or an ulcer. We have neovascularization here that we can finally see with magnification. We've got these 2 solid representations of disease, and our photography gives us increased diagnostic yield, better directed therapy, and categorically we're in keratoconjunctivitis. I'm not taking chest rads of this cat. I'm not thinking of uveitis or life-threatening diseases. I am thinking of herpes virus. And I sprinkle in just a little bit of shelter medicine, medical therapies here, and this is the most common thing that we're treating. So if there is not any secondary bacterial infection, this would be my preferred starting treatment option. It involves erythromycin because it's well tolerated by cats, and if I miss the Chlamydophila and Mycoplasma that might have been co-infected, erythromycin, a macrolide, gets intracellular and kills those organisms with a 3-week pulse on average. And cidofovir is unfortunately not commercially available, but Wedgwood, Stokes carry a 0.5 or 1% solution. I use 0.5. And the great thing of this antiviral drug relative to others is that it's been proven effective at twice daily therapies. It's just a little expensive, unfortunately. For about 6 weeks of therapy, it costs about $50 to $60. Treatment option 2, and I give the owners both options straight away. I ask, can the cat be pilled? Most owners say I'd prefer a drop, but then they'll go home with the cidofovir and the meds and say like, okay, I think we'll try a pill now. And that's famciclovir. So UC Davis, Sarah Thomasy and David Maggs have done the most research out of any feline antiviral with this oral therapy, famciclovir. The metabolism of this drug through the liver and its prodrug, penciclovir, is super confusing, and through about 9 manuscripts has them with dosing intervals and ranges all over the map. A recent review gave a recommendation of 40 to 90 milligrams per kilogram once to 3 times a day, which is like, what does that do for us? So these are big tablets and they taste horrible. These are the 2 options that we have commercially available. You can get it compounded, but it allegedly is like worse than giving a cat oral atropine. It's going to make them salivate when it's compounded into a liquid. You can't mask this metallic taste that it apparently has. So pill pockets, and I usually start out with 250 milligrams twice a day, just because it's easy to get the pill down, and it's within one of the effective dose range according to the people who've done the most research. For refractory cases, I might go up to 500 milligrams 3 times a day. And these cats don't necessarily get the classic dry eye, but this is another Amazon product, or maybe it's MWI. Eye Drop Vet Plus gets the portion of the tear film that cats seem to be affected by with herpes virus, which is that they lose specific conjunctival cells that produce mucus. The virus seems to have some sort of preference for goblet cells. Cats without herpes versus with herpes have a markedly depleted goblet cell and mucus production potential. This drop is the most mucinomimetic option that's available. So for a cat that doesn't have a concurrent corneal ulceration, this is a great palliative option to make them feel more comfortable and relieve the signs of conjunctivitis. So here's a couple of herpes virus strategies, both assuming that we don't have secondary complications like bacterial infection causing stromal loss, corneal perforation. Those are cases that require much more severe therapy. So the natural course, I think I have recheck in 2 weeks. The natural course of spontaneous herpes virus infection is a 2-week disease, and it tapers off to nothing. So I recheck at that point. I expect them to be cured by that point, either naturally because my therapies didn't do anything, or if they didn't, then I step up or alter some therapy, consider additional diagnoses, or that I'm doing something wrong or not treating enough. So I expect resolution within 2 weeks. Yeah, and abnormal, so that's for the primary. We know that herpes virus has a primary infection. That's where we see all of our very diseased upper respiratory tract kittens, recrudescence, and then the virus-host relationship for the recrudescence is what gives us these prolonged 3-week battles all the way up to years of this strange play between the immune system and the ocular surface, and that's where the 2-week comes in, because I want it to be, normal. Increased donor buy-in, so this is what we see without magnification. We can all agree that the cat's right eye is diseased, but if we could get this blown up photo where I can see the lower eyelid rolling in, what's the brown opacity on the surface? I think I heard sequestrum. So sequestra are just a devitalized area of corneal stroma. I often recommend a quick surgical procedure called a keratectomy, and I slide healthy cornea into the defect. We're going to have increased buy-in from any party that's responsible for this cat that it needs surgery of its eyelid to remove the constant irritation and cause for the entropion. This is the dynamic between adnexal disease and surface disease. If we can show clients these images, I will take photos in the exam room, wheel my little stool over to the clients and show them this is what's happening with your animal's eye. Like all these vessels, this little brown spot doesn't belong, and I think that we should do something about it. And I find that it helps me communicate a lot better. Improve medical record maintenance and tracking disease over time. We can find longitudinal changes without just the owner's history of the disease progression. For instance, this was a common dog in Texas, the Catahoula, and this is how it presented on the left with copious mucopurulent discharge. This is an absolute KCS case, 0 for Schirmer tear production. And we performed a parotid duct transposition, kind of rewired the parotid duct and put it into the eye. It's now salivating into its ocular surface. The owner's not entirely happy because it still thinks that the dog is squinting, but I show the comparison. It's like we've completely eliminated the mucopurulent discharge. There's clearly less inflammation because we have about half the vessels. And actually getting the dog an automated food dispenser, treating it 6 times a day with little small meals was the solution. It's just the dog wasn't eating enough and not salivating enough into its eye to get the benefit. And my favorite part, this is all of this is my most enjoyable part of the job, is getting emails and texts from you and being able to actually answer these questions. I feel like I'm kind of riding a precarious telehealth jurisprudence because I'm speaking all over the country and potentially on recordings violating consulting appearances, but you will receive a very generic hands-off answer. Like, it might be persistent pupillary membranes, and that might not be a problem at all, but you should probably talk to someone locally. I will tiptoe around it a little bit, but I love the collaboration, so please do email. And here's just a few examples of referring veterinarians that I asked them, can I use this for for my lectures, and if so, how do you want your name credited? So I spoke at AVMA last year in Denver and got this image from Dr. Teal of another great example of persistent pupillary membranes. This is a former vet student at Texas A&M showing me a case of dry eye that she's been treating successfully. The vessels are no longer active and the pigment is clearing. We still have quite a bit of corneal edema, but I can tell, I can see all of this. This was an intern at Texas A&M. This poor dog was shot with a shotgun and pellets went through both corneas. I find that the millennials and generation, what are we on now? Z? X? I don't know. Anyways, the kids these days are, this was the first time that I saw someone send me an OD and OS, and you can do that, apparently. So I appreciated that. This is like a textbook photo from a local clinic next to Texas A&M. This is nodular iritis. There are specific conditions that we think about, and I can give fairly accurate information at least about the iris because it's a perfect representation of the disease. I don't know what the skinnier photo is. It's the only veterinarian who's used the slit lamp technique with a direct ophthalmoscope to highlight an anterior lens capsule opacity, but it was perfect, and it's perfect for this lecture. So we'll talk about how to do that. And then lastly, the skill development. If you have a passion for photography and you are not queasy about ophthalmology, you may find that you find things that are kind of beautiful about pathology in the eye. And this is one of those examples, just a photo that I took that I think represents chorotic precipitates really well. The big pink curvilinear structure in the top edge of this photo is histoplasmosis granuloma, just shedding chorotic precipitates onto the cornea, or inside the cornea. So these are the traditional methods that don't help us collaborate, but I heavily encourage them. I tell students and visiting veterinarians that you will not get enough out of your examination with every examination unless you magnify all of the structures of the eye. We can't perceive the details that we need to see with our naked eye, and sadly, especially after we turn 40, because then presbyopia settles in and we need bifocals, and you definitely don't have the near vision to accommodate to see it. So we need an optivisor loop or the magnifying glass from the otoscope. What I'm going to talk about, and I'll distribute to as many people who are as interested, is this little blue rubber band, the Macrolens. And I don't have a financial relationship with it. This doesn't benefit me at all. I do get emails from the CEO of this company saying, what's happening? So he's very happy about it, but we haven't partnered up in any way, or just regular point and shoot cameras. So step one, choose your camera, take some photos. Second step, you can do post-processing, which makes people's eyes glaze over. No one wants to go to Adobe Photoshop and learn, it basically requires a college degree to learn how to use. I don't know if anyone uses Photoshop, but I've tried for the past 4 or 5 years, and I am just as bad at it now as I was before. Or you can just simply use the Macrolens, and you might even be able to do post-processing there. I'll talk about simple techniques. So here is an example of a dog that I took a photograph of from a distance, not even at the closest working distance of the camera, but it was in focus. So you can see my little camera roll at the bottom. This is what you guys would be seeing. Zoom and crop. All we need to do is take 2 fingers, zoom into the image, and now we get kind of 2x magnification. So it's looking a little bit better. We can do that with current smartphones, which have like 12 megapixels. We can do that twice before it starts pixelating. Whether it's an Android or an iPhone or Apple-based technologies, there are, if you have the inclination, there are little buttons on the bottom of your natural camera software that allow you to use post-processing options. Mostly these are like used for Instagram filters for making things look sepia toned or whatever you want. But you can use them to your benefit. I clicked on the little ... option here, and it gave me a magnifying glass option, which seems to sharpen and enlarge. That little circle around the eye now is enlarging it about another 2x. And this is our final product. I see the fluorescent lights in the room are perfectly curved, that this isn't an ocular surface disease, but where the lens should be, there seems to be a blood clot. So I know just through simple adjustments that took about 30 seconds that this dog likely has uveitis, and it has a bleeding form of uveitis. So I'm going to do the simple things. I'm going to check the dog's blood pressure. I'm going to do a blood smear, look for platelet counts. If I don't get any wins there or positive hits, I'm going to do a coagulopathy test. And if I don't get any hits there, I'm going to look for the classic forms of uveitis. Infectious, I'm doing a 4DX, fungal panels, neoplastic, I'm doing chest radiographs. If the dog lost weight, I'm doing an abdominal ultrasound. I know these things do not apply to shelter medicine, but I'm just letting you know that this is, we have at least a direction to take the case, or at least to treat it empirically. This is a neopolydex eye rather than an optimune eye. So start, finish, just in seconds. Just zoom, screenshot, a couple of adjustments that you really don't need to do, and we found uveitis pretty reliably. So it's all the things that we just talked about with photography in general, diagnostic yield, better directed therapy, people buy into it, et cetera, et cetera. This is a case that I actually didn't diagnose at the time of the examination, but as I was showing the owner photos on my phone and just zooming in, the diagnosis just popped out at me because it's the first case of, well, you'll see in a second. These are the original photos. You can do this in Microsoft Word or PowerPoint. All you do is click on the image, and then at the top bar, you'll see Format pop up as an option. It gives us an option to crop, so I just use this little crop tool to frame the eye. I'll do the same thing here, and then just enlarge the image. It's the same thing as zoom and crop. And we actually have, if you right-click on the same thing, formatting options, we have this picture adjustments option. And this is like the most bare bones Photoshop that you need to play around with. I just dialed the brightness up from where it was, and before, zoom and crop, and now we can see just through PowerPoint adjustments, we have a superficial corneal ulceration, and you might be able to see tiny little spikes present here, and they were better represented. So this was a prickly pear cactus. And this was a light microscope image. They're about 2 millimeters long. They've got these little vicious barbules that help them just penetrate deeper and deeper into the tissues. Interestingly, tarantula hairs will do the same thing. So if that's a history of any presentation, someone aggravating a tarantula, they might have a similar appearance. But just through looking at a photo with a little bit of increased brightness and enlargement, simple techniques, we found eyelid disease causing secondary surface disease. Here's a cat that was sent to me from a vet in town that said, "What do you think of this eye?" Did the same thing, just zoom, crop. And despite the fact that there's mucus on the eye, I ruled out ocular surface disease, and I could see this kind of donut-shaped appearance of the iris with a blood clot in the center, and that's consistent with iris bombay and a severe form of uveitis. So again, tiptoe around that diagnosis, and I think it is consistent with uveitis. So option 2, which I'll distribute, is smartphone macro lenses. These range between 4x magnification and as high as 100x magnification. If you type this into Google Shopping, you will see so many options, things that look like science kits. And this is the one that I think is simplest. It does come with a limitation for most smartphones that it blocks out the light source. So you'll need to provide an independent light source. This is where I'm rarely saying keep the room lights as bright as possible or use an overhead surgical light to illuminate the eye. When I do these images on my own, I will have someone with a transilluminator illuminating the eye. I'll show you that technique in a second, except for the iPhone 10. They've got vertical cameras, and the LED flash on the back of the phone is not covered by this. You just put a piece of tape over it so that it's not as bright. If you want to write down this, if you don't get a chance to get this afterwards, it's easy macro. So here's an example of a couple of rotating interns that were working on the emergency service. One that did not use the Macrolens, I give this to them during the orientation, saying we can help each other better if you get better images that you can send me. And intern A sends me an image of the Shih Tzu's eye, and I could not adjust or crop or get this focused to the point where I'd say, I need more help. Versus intern B, who sends me a different eye, little video. Does anyone know what this is? So the iris is wobbling. This is called iridodonesis. And it can only be one thing. This is a lens that's fallen into the back of the eye that's no longer supporting the iris, and the iris gets floppy. So it's a lens instability. More of a shelter medicine relevant example. Just call it out if you think that you know what we're looking at, but it'll get better each time. So this is no magnification, just the smartphone. Say again?
Iridocorneosneakia.
This is symblepharon, and most likely caused by the early herpes virus infections or any infection where you'll see a delayed opening of the eyelids. That little pus at the inside corner of the eye. That's usually herpes virus just running amok, destroying all the epithelial cells, and then the conjunctiva doesn't know where to heal. So I could just zoom and crop the video, and I get about 2x magnification, and I get a better look, but it still looks like it could be just pigment around the eye. This looks a little bit more like symblepharon, conjunctiva attached to the cornea. And lastly, this is without any adjustments in the macro lens. We're seeing individual vessels. I can see what looks like the third eyelid directly attached to the ventral half of the cornea. We'll rotate it around to the other eye. Same thing. The technique that I use is that, actually I'll just show you in the next slide. But I could zoom and crop into this video and get up to 8x magnification, maybe do it again, 16x magnification. It is an incredible resource that just allows us to basically replace those $1,000 cameras. And I love the fact that we can get compressed videos really easily. Videos allow us to get different focal points and different things in focus. You can take screenshots of these, if you don't want to send a video or if it's too large, you can just pause the video, scroll to the portion that's most representative, take a screenshot, and then just send a smaller shot as a smaller file. So you see the macro lens wrapped around the camera. A lot of you guys would be asking what happens with double and even triple lenses are coming out with smartphones nowadays. I know iPhone's the best because I use them. It is the most peripheral camera, the camera lens that is closest to the corner of the phone. So that would be the top one on the iPhone 10 or the one more peripheral on the iPhone 6 Plus or 8 Plus, 7. So this is my own cat, just showing you kind of side-by-side videos of what the image acquisition looks like and the image that we are actually producing. You see my thumb is tapping on there's a hair on the cat's cornea here. My thumb is often tapping there to refocus because it'll pick distant objects and you'll see things out of focus. There is a student with a transilluminator in between my phone and the eye here. And I'm only about 1 or 2 centimeters away from the eye. I'm collecting a video. I just paused and then got this representative image of a normal eye. So our last topic, before we go through a little demo of how to do it, is viewing the fundus with the smartphone. So here we have a cat who may be sneezing, maybe has a Roman nose, and if we can get this image, we know that it is consistent with Cryptococcus chorioretinitis. There's not many other things that produce this pattern of solitary tan lesions that are elevating the retina forward. You don't need to know that that's the pattern, but maybe we could share and then point the case in the right direction versus normal. We have something to compare it to. This is something that, if you search through the literature, especially the human literature, there's only been a couple of papers published in veterinary literature. They are kind of handicapped by the fact that they are only using products that are paired with software that's HIPAA compliant and that is an FDA-approved medical device. And there's only 2 that I'm aware of, and the unfortunate thing is that the one that adapts to the panoptic ophthalmoscope hasn't been updated, as far as I'm aware, since the iPhone 4. And these little plastic connectors just don't fit the bigger phones, so you're stuck with your one imaging camera. Plus the iPhone 4, I think it was closer to 7 megapixels, and its autofocus adjustments aren't as good, so the images aren't as good. I'm not sure if this has been approved, but it's $1,000, so who cares? The DI, this is the one that you'll see the most published information. It's actually really interesting. This one is, I think, compatible for multiple phones, but the FDA licensure or approval might have restricted it again, just the iPhone 4 or 5. But we're starting to see what my goal is for veterinary medicine to move towards is that in like third world countries, our underserved communities from ophthalmologist perspective, that this is allowing local human practitioners to link up with human ophthalmologists in a really effective way, in a low-cost way, without having that $100,000 fundus camera. This has been assessed in veterinary medicine. It is a good option, but I think that you can get images without it. Cornell actually published this. The amazing thing about this little adapter, which just connects to the top of your phone, it's just a piece of plastic that has housing for an indirect condensing lens, is that if you want to write this down and if you have access to a 3D printer, which are getting more and more accessible, they made it open source. So they will sell you this for $150, but if you want to make it yourself for $10, the ODocs/-tech option allows you to print this on your own. And then it just requires a separate order of a couple of hex nuts to assemble the whole thing, and it's really clear-cut and instructive. So Dr. Ledbetter and Espiniera here published these images using this technique. I do this. I have this device as well, but I try to, since I'm not entirely sure students leaving Texas A&M are going to go through the effort of buying this, I have been teaching the technique just freehand without this adapter. By the way, condensing lenses are often a sticking point for whether or not you can do indirect ophthalmoscopy because we get this perception that they're somewhere between $300 and $400. The company, VOLK, that sells the majority of condensing lenses has an amazing bulk option. This seems like a glitch that they're going to fix at some point. But if you buy 10 lenses, and I'm not sure if practices could cooperate, maybe 3 practices across the state, say you want to go in together for VOLK lenses, you can get them for $150. 10 lenses of equal quality to what we use in the clinic. Equal quality to these $300 to $400 lenses. The only difference is that they have a silicone periphery rather than the stainless steel periphery. So you just need to protect them a little bit more, but they're the same glass, they're just as rugged. And it's the kind of the gold standard for indirect lenses. They're not plastic. So there are 2 techniques if you are not going to buy these adapters. One is the direct technique where we just move a phone just as close as you would a direct ophthalmoscope, and the other is the indirect technique where we use the phone as our traditional light source for indirect ophthalmoscopy. So step 1, just for the fun of it, if everyone just pulls out their smartphone now, we'll just look at the back of the phone, whether it's an Android or an iPhone. Most of you will see 3 circles, the camera lens, sometimes 4 if you've got a double lens, and the LED white flash. So we are only covering the LED flash with a piece of tape. Step 2, and you can just try this on your own, and go to video mode on your camera. And in the top of video mode, once you're toggled onto that, hit the little light and just toggle the flash on. A lot of lights, it's like a concert. And then that's all I needed you guys to do, just to get that far. And then these are 2 students that were on day 1 on the rotation, and one of them brought their dog in. And I said, those are the instructions. Now see if you can image your dog's eye. And I was telling them, now move closer, closer, closer. And you have to move to within about 1 centimeter of the eye, and you can watch her learning curve in real time. This is the first time that she did it. See how she's balancing the phone against the dog's muzzle? So not perfect with her first time, but you could see some glimpses of the fundus straight away. And now she can pause that video if she recorded it, especially if she recorded it in slow motion, because there's extra in-focus frames. It's just a bigger file on her phone, which you can delete straight after you get your still frame screenshots. And now she's got some images of the fundus that are permanent. And where I go from there is you can build kind of a mosaic representation just by taking screenshots at different aspects of the video. Does anyone know what species this is? This is an alpaca. I think they have the most beautiful fundus out of all species. They just, this kind of tortuous vessel pattern that seems elevated. But yeah, we get little screenshots representing different areas of the fundus as we're seeing it. And this is the natural limitation of the direct technique, is that we only get little glimpses. It's more magnified than you need. This is why I prefer the indirect technique, because I need to twist and adjust. A lot of patients aren't that patient to sit through this entire technique, but if you have the time to take multiple screenshots, you can get a pretty complete fundic exam. This is a dilated cat, and tons of bonus points if you can name a suspicious disease that this cat has. The abnormality is the hyperreflective periphery of this massive lesion and the hyperpigmented center around the optic nerve. I didn't know what it was at the time, so it's a shot in the dark for you guys. I tested for histoplasma first because I just happened to be seeing a ton of it in Texas. But it turned out having an incredibly high titers for IgM and IgG for toxoplasma. But just incredible quality, better than the majority. We just bought a $15,000 fundus camera that we're really disappointed takes images that are much worse than this. Limitations of the direct technique. Any animal over the age of 6 or 7, cat or dog, you're going to struggle to get crisp images. Luckily, this is shelter medicine, so where the majority of the population is a little bit younger. It helps to use tropicamide first. If you have it in the clinic, wait 10 minutes after a drop, although you don't need to. So if you flick off the room lights and get that pupil dilated and put maybe 2 pieces of tape over your LED flash rather than just one, you'll probably be able to get through the pupil. The majority of my videos are through that technique, just flicking off the lights. So nuclear sclerosis. If you have an actual lens opacity like a cataract, this is a Great Dane with a triangular cataract, the camera's natural software will autofocus on whatever's in front of it, and it's focusing on the cataract, or it's trying to, over the fundus. This dog that we're about to see has nuclear sclerosis, but it has peripheral pathology. I can see just a little spot of hemorrhage in the periphery, but it's fuzzy because of the nuclear sclerosis. And it doesn't really represent what I'm trying to achieve. If you have the plus phones, iPhone 6 Plus, 7 Plus, or 8 Plus, the difference or the distance between the LED flash and the camera lens is a little too far away for this technique, even when the eye is dilated to prevent shadowing. So the flash is hitting the nasal edge of this iris. I can still image the back of the eye, but you're seeing that half the eye is shadowed because the flash and the camera are too far apart. A limitation that I didn't write down, if you have the Google Pixel is fine. That's an Android platform, I think, that has a peripherally positioned lens. Unfortunately, with the direct technique for like Samsung phones or any phone that has a centrally positioned camera on the back, we usually can't align the camera lens close enough to the eye and get an image. So you're stuck with the indirect technique, which is superior as far as imaging the fundus. It's just a little harder to learn. So borrow someone else's iPhone, because there's usually someone in the clinic that has one. Because they're peripherally positioned and the nose doesn't get in the way. So here's just the representation of the distances between the camera and the lens. You see that the more peripheral camera lens is the one that you use for imaging the fundus. This is the 8 Plus, and you see that distance between the LED flash on the far right and the camera lens on the far left. That's the wide angle lens. The telephoto lens is what camera developers have used for artistic photos like portrait mode, and it's less applicable for these techniques. But the iPhone 10 went back and turned it back into a fundus camera more. So they fixed the glitch. I don't think they're paying attention to this at all right now because there's nothing FDA approved about this. Although I should say, there is a disclaimer from an ophthalmologist that actually studied the light intensity of the iPhone 5 at the time without any tape over the LED flash, just running continuously on the retina. And they measured the lumens, the objective measurement of the flash, and determined it to be as safe, actually safer by, I think, maybe 10 or 100-fold than the slit lamp or indirect ophthalmoscopy that we traditionally do for our exams. You just don't, like any bright light, you just don't want to leave it over this on the retina for any length of, extended length of time. So these are the two preferences. If you have either one of those, it's easier for the direct technique specifically. Indirect fundoscopy, exactly the same setup. Put a piece of tape over the flash, get an indirect condensing lens, and then you're off and running. It is a little different than what you learned originally, where your light source is at your temple. Your light source is a lot closer to the patient here. So we're getting it to the point where we can get the image of the fundus as large as possible. Here's kind of a technique example of two side-by-side videos, me doing an examination on a cat who actually does have histoplasmosis. Those little hyperpigmented foci within the tapeta are the disease. And you can see the setup. I'm about a foot away from the cat with my right hand. Left hand is just balanced. Go through that last video again. See that I'm using my pinky ring finger to stabilize the lens over the eye. and the restrainer is actually opening the eyes for me. And not every image, not every part of the video is perfect, but I can get this still representation, zoom and crop, that's actually pretty darn good. It compensates for the direct limitations. So here's that Great Dane with that triangular lens opacity that we're not able to get by. But with the indirect technique, we can get light around that cataract and get a solid image, or at least one or two images. You can still see that cataract, but we're getting a wider field of view in the image, and we can get past the problem. Here's that peripheral lesion with nuclear sclerosis. This dog actually had a retrobulbar tumor pushing into the back of its eye. And with indirect, you can actually see that the fundus is billowing towards us because the tumor is pushing into the back of the eye. You can see that topography and furrowing as there's a bulge in the back of the eye. It really does help, especially with the bigger phones, if you have someone tapping on the image as you're taking it to adjust the exposure. So when you tap on your phone, if you're taking a picture of a portrait or a landscape, we're all familiar with the fact that the phone, before tapping on the screen, gives you kind of a washed out image until you tap on it. It adjusts the exposure. It's really helpful when you work with a tapetum. I do find that when you get nice images with the direct technique and you don't have the limitations of lens opacities or small pupil, et cetera, you get really nice, rich, focused images. With the indirect technique, it's often harder to balance the light because it's taking so much more of it. So I get sharper, crisp. I didn't save the best screenshot in the left image, but I think I get better quality, and I think you'll see it. The example of the cat with toxoplasmosis was a great example of how crisp those images are. So just in summary, indirect, more challenging to learn straight away. I would love to see if you guys come up with any images. I've yet to receive them, so it would really help these presentations out. Really good for a small pupil if you don't have tropicamide or if you can't control the environment, room light environment to dilate the pupil with darkness. Good for lens opacities and good with any phone. You guys don't have proceedings, but timely enough, all the techniques that I talked about here are going to be in next month's clinician's brief in the August edition, so you can look out for that. But again, I have typed up proceedings, so if you'd like a play-by-play kind of written instruction to go along with these presentations for any of these techniques, I can send you those as well. Just send me an email and I'm happy to take care of it. All right, so that's it. Thank you very much.